Good morning. I'd like to welcome everyone to the 57th meeting of the Advisory Committee for Blood and Tissue Safety and Availability. I'd like to welcome the people in the room as well as the people who are online. It is my distinct pleasure to begin the meeting by introducing Admiral Rachel Levine. Admiral Levine serves as the 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services, and she is the head of the U.S. Public Service Commission Corps and chairs the Blood, Organ, and Tissue Senior Executive Council. Admiral Levine fights every day to improve the health and well-being of all Americans and build a stronger foundation for a healthier future, one in which every American can attain their full health potential. Admiral Levine's storied career, first as a physician in academic medicine, focused on the intersection between mental and physical health, treating children, adolescents, and young adults. Then as Pennsylvania's Physician General, and later as Pennsylvania's Secretary of Health. She addressed COVID-19, the opioid crisis, behavioral health, and other public health challenges. This is an abbreviated introduction. If you would like to see the full biography, please see the written notes. Admiral Levine.
Well, good morning. Thank you for that welcome. And welcome to the 57th meeting, 57 meetings of the, have you all been doing 57 meetings? Advisory Committee on Blood and Tissue Safety and Availability. I would like to thank all of the committee members for being here both in person, but also virtually today, and for devoting your time and your expertise to this committee. I also want to express my appreciation to Kay Hayes and her Office of Infectious Disease and HIV/AIDS Policy, and our team for laying the foundation for this important meeting. As the Department of Health and Human Services Blood Safety Officer and Chair of the Blood, Organ, and Tissue Senior Executive Council here at the Department of Health and Human Services, I know that the blood collection industry has been challenged by a variety of issues over the past number of years. HHS is committed to following the best available science to inform and revise policies, including policies related to blood donation. At the same time, HHS has recognized how the previous policy was stigmatizing to the LGBTQI+ community. Later during this meeting, the FDA will present on their recent move to an individual risk-based assessment so that everyone will be asked the same questions, regardless of their sexual orientation or their gender identity. Our goal is that with the implementation of this individual risk-based assessment, we can inspire a new generation of blood donors by bringing blood drives back to colleges and universities, and that we can continue our work to end stigma against the LGBTQI+ community. Recent events, including manufacturing challenges, have raised concerns about our capability to respond efficiently to unforeseen emergencies or disasters when large amounts of blood and blood products are required urgently. Today and tomorrow, the committee will explore and discuss ways to address our need for expanded surge capacity in the United States blood supply. While the COVID-19 pandemic revealed weaknesses in the blood supply chain and intensified these issues by causing disruptions in the production and shipping of supplies, the challenges we face today are not from COVID alone. The small number of manufacturers that produce blood supply products have faced immense disruptions with the damages caused by recent hurricanes, which severely limited their manufacturing capabilities. An interruption of just one vital link in the supply chain can upset the already fragile blood collection system, and these critical issues have led to shortages of essential supplies such as blood bags and collection kits. Sustained shortages will have profound implications for patients if the underlying root causes of these issues are not addressed, as of course there is no substitute for blood and blood products. It is one of our utmost responsibilities to address the vulnerabilities in our blood collection system. We must be proactive in our approach to ensure that we have the capacity to meet the demands for life-saving blood and blood products when they are most needed. Over the coming days, the ACB-TSA members will consider presentations from several experts and stakeholders in the industry on a variety of topics related to surge capacity. I know that the speakers you hear from will be able to provide insightful information and help guide a fruitful discussion. I'm also aware that there is no universal solution, and we certainly welcome open and honest discussions and creative solutions to consider ways to address these challenges and strengthen our surge capacity. So I look forward to hearing your thoughts on this very, very important issue. In addition to the critical conversations on bolstering our surge capacity, we'll also hear updates on the red blood cell antibody exchange project, the tissue tracking working group, and our successful Giving Equals Living campaign. Now, I am excited to have the opportunity to welcome a few new members to our Advisory Committee on Blood and Tissue Safety and Availability to partake in the essential conversations that we are having this week and in the future. So without further ado, it is my honor to swear in the following three members to the committee. Ms. Diane Wilson, Community Blood Center, Community Tissue Center. Dr. Cassandra Josephson, Johns Hopkins School of Medicine. And Mr. Lou Barnes, American Association of Tissue Banks. So please stand and raise your right hand and repeat after me. I do solemnly swear that I will support and defend the Constitution of the United States against all enemies, foreign and domestic, that I will bear true faith and allegiance to the same, that I take this obligation freely, without any mental reservation or purpose of evasion, that I will well and faithfully discharge the duties of the office on which I am about to enter. Got it. So help me God. Thank you. Thank you. Congratulations. Well, with that, I would like to thank you all for being here today and for taking the time and your energy to share your knowledge and expertise over the coming days. I am looking forward to reviewing your recommendations to increase surge capacity for blood and blood products. And now I'm going to turn things over to Jim Berger from our staff, who always is doing such a fantastic job. Thank you, Jim. And thank you all.
Thank you, Admiral Levine. Before we get started and doing the roll call, I want to just make a quick announcement concerning those that want to have lunch. Paperwork is left at your desk. If you could indicate on there what you want and put that information in the envelope, we'll come around and pick it up so lunch can be ready for you. It's going to be at the Pot Belly. Any questions?
If we send our order form in to Stephanie beforehand, does that satisfy that requirement?
It should. Yes, we'll make sure it does. I got the word that it meets that requirement. Okay, with that, Claudia, turn it over to you.
Thank you so much, Jim. Welcome again to everyone for joining the first hybrid meeting of the ACB-TSA. I joined the ACB-TSA just as COVID struck, so this is my first in-person meeting, and I'm very happy to be here with everyone. I want to take this opportunity to especially thank Jim Berger and his staff, Lauren Overman, Allison Petkoff, and Sarah Parker, and others I'm sure whom I don't know, for making this meeting come together so smoothly. I'd also like to thank the working group that developed the recommendations that we'll be dealing with today. They are Bill Block, Sally Cagliotti, Louis De Leon, Thomas Gniadek, Jed Gorlin, Dave Green, Mary Homer, Jay Menitov, Suchitra or Suchi Pandey, Diane Wilson, and Pompey Young. So thank you. I also have to say at this point that I wear a lot of hats. I'm primarily the medical director for the blood bank at the University of Minnesota, but I'm also the chief medical officer for AABB. And the opinions and anything I say today The hat I'm wearing is as chair of ACBTSA. I am not representing University of Minnesota nor AABB. So the Advisory Committee for Blood and Tissue Safety and Availability deals with blood and tissues, safety and availability. Today we're going to be hearing, or over the next few days, we're going to be hearing talks that cover some of these other topics, such as the initiative for the alloantibody exchange, such as tissue safety. But the recommendations that we're going to be working on, the 13 recommendations that you have seen, primarily deal with blood, not tissues, and they primarily deal with availability, although safety is always an important component for anything to do with blood. The recommendations, or the name of the working group, was surge capacity. However, we wanted to address all aspects that would contribute to us of being able to be better prepared for an emergency that requires blood. So in order to do that, we need to discuss matters that allow us to meet a surge in demand, surge capacity. We need to look at stockpiles because we need to have the materials available quickly and readily to be able to meet a surge in demand, and also to deal with changes or vulnerabilities in our supply chain that make it difficult to or impossible to manufacture blood without having a stockpile. We also need to talk about emergency measures that we should consider taking if we need blood quickly. Are there steps that we can consider changing so that blood can be manufactured as quickly as possible if that is needed? Those are pressing matters, and those are addressed largely in the recommendations, as well as donors. So long-term problems, we need to always shore up the donor supply. We need to make sure that we have a diverse donor base so that we can meet the needs of all of the patients that we see in the hospitals. We also have a major long-term problem that involves supply chain, that involves reimbursement and billing, the infrastructure of the blood community. We have many, many blood centers, most blood centers, working at a very narrow margin. This cannot continue. We need to be able to have a functional blood collection establishment so that we can always have enough blood available. And so some of our recommendations are very long-term and will deal with those issues. And those are big issues, but we need to start chipping away at them so that we can make the blood supply more strong. So as I said, there are 13 recommendations, and due to some factors that were outside of our control, the 13 recommendations were made available to ACBTSA members and stakeholders only in late June, which was truncating the usual 30-day comment period. And for that, we apologize. We did not want that to happen, but it was somewhat outside our control. Naturally, we don't want to miss hearing the comments from all of the stakeholders in the field. And so we want to make sure that we take measures so that those comments are available in the record and incorporated into the recommendations. So what I'm going to do, what the committee is going to do, is every recommendation that we pass over the next 2 days will be considered a very near final draft. That will then be open to a 15-day recommendation period. And during that time, we'll look at the recommendations, incorporate them into, we'll look at the comments, incorporate them into the recommendations, and then the final language of the recommendation will be voted upon online. I think this is the best way to make sure that all of our voices are heard. So before we dig into the recommendations, we'll begin today with an update on the ADVANCE study and individual risk-based deferral from Peter Marks. We'll then hear a series of presentations that deal first with surge capacity, and then after lunch, we'll turn our attention to stockpile. So with that,
Claudia, we need to have the introduction of members. So we can...
but first we need to have an introduction of the members.
Since this is the first meeting in person for many of you, what I'd like to do, instead of just doing the roll call, just go around the room, announce your name, where you're from, what you're representing, and then we'll do an introduction with those that are dialed in online. So, Ray, if you'd like to start out.
Good morning. I'm Ray Goodrich. I serve as the Executive Director of the Infectious Disease Research Center, Colorado State University. I'm also a professor in the Department of Microbiology, Immunology, Pathology at Colorado State University.
Good morning. I'm Marilyn Levy from the Division of Transplantation at HRSA.
Good morning. My name is Lou Barnes. I'm the American Association of Tissue Banks representative, most recently running an accredited tissue bank in South Florida.
Hi, I'm Cassandra Josephson. I'm the director of the Cancer and Blood Disorders Institute and the director of blood transfusion and apheresis at the Johns Hopkins All Children's Hospital. I'm also a professor of oncology, pediatrics, and laboratory medicine at Johns Hopkins School of Medicine.
I'm Dave Stronczyk. I'm the acting chief of the Department of Transfusion Medicine at the NIH Clinical Center and director of the Center for Cellular Engineering at the NIH Clinical Center.
I'm Claudia Cohn. I'm medical director of transfusion medicine at of the blood bank at University of Minnesota, and I am chair of the ACB-TSA.
Hello, I'm Diane Wilson, and I'm the chief operating officer of Community Blood Center Community Tissue Services.
Good morning. Jim Berger. I serve as the designated federal officer for the Advisory Committee on Blood and Tissue Safety and Availability.
Good morning. Kay Hayes, Deputy Assistant Secretary for Health Infectious Disease and also Director of the Office of HIV/AIDS Infectious Disease, and also serve as the alternate designated official with Jim here, and also serve as the Executive Director of the Presidential Advisory Council on HIV/AIDS. And it's so good to see everyone here in person.
Hi, I'm Dr. Susan Gawel. I'm Senior Director of Medical Affairs at Roche Diagnostics, for where I provide medical support for the donor screening products. I'm on the committee as someone knowledgeable with regard to donor testing. However, I am not anything I say should not be construed as representing Roche or the diagnostic industry. Thank you.
Hi, good morning. My name is Stopper Baker. I'm the director of the Division of Human Tissues, and we have a new sub-office it's titled the Office of Cell Therapy and Human Tissue. We're in a new super office, the Office of Therapeutic Products, and that's all within CBER at FDA.
I'm Judd Gorlin, Medical Director of Blood Centers in Minnesota, Nebraska, and Kansas City, Transfusion Service Director at Hennepin County Medical Center in Minneapolis and St. Paul Children's, and Chief Medical Officer, America's Blood Centers.
Thank you. With that, I'll start with the public members that are online. Once I say your name, if you're available, please indicate present and where you're from. With that, I'll start out with Bir and Miriam.
Hi, Burianda Mariam. I'm professor of medicine, hematologist at the University of Connecticut Health.
Thank you, Bir. Next, Sally Cagliotti.
Good morning, Sally Cagliotti, CEO of Creative Testing Solutions.
Thank you, Sally. Next, Elisa Gordon.
Good morning. I'm Elisa Gordon. I'm professor at Vanderbilt University Medical Center in Nashville, Tennessee. Thank you.
Thank you, Lisa. Moving on to Michelle Kamika.
Good morning, all. I am a professor at the College of Nursing and Health Sciences in Miami, Florida at Florida International University. It is a pleasure to be here with you all today.
Thank you, Michelle. Daryl Core.
Good morning, everybody. I apologize for not being able to be with you in person. I'm an anesthesiologist and intensivist at Mayo Clinic in Rochester, Minnesota, and served as our prior director for patient blood management.
Thank you, Daryl. David Perez.
Good morning. My name is David Perez. I'm the former CEO of Trimo BCT, and I currently serve as a board member for medical device and cancer diagnostics companies.
Thank you, David. Jim McPherson.
Yes, Jim McPherson. I'm the former CEO of America's Blood Centers. I'm currently an independent consultant on blood and plasma issues and chairman of the board of Global Healing, a international developmental NGO.
Thank you, Jim. Next, Paul Ness.
Yes, I'm Professor Emeritus of Pathology and Medicine at Johns Hopkins and the former director for 40 years of the Transfusion Medicine program at Johns Hopkins.
Thank you, Paul. Next, we'll have a roll call with the representative members. Lynn Ewell.
Good morning. I'm Dr. Lynn Ewell. I'm presently Vice Chair of Laboratory and Transfusion Medicine, and my role on this committee is fulfilling AABB liaison.
Thank you, Lynn. Next, Gary Markland. Moving on to Benny Yang.
Hi, everybody. This is Benny Jiang. I'm professor and chair of the Department of Ophthalmology and the director of the Shea Eye Institute at the University of Pennsylvania Perelman School of Medicine in Philadelphia. I'm a corneal transplant surgeon by training, and I'm representing the Eye Bank Association of America.
Thank you, Benny. Eric Santiago Giuliano. Next, I'll go on to our ex officio members. Nicole Verdun.
Hi, good morning. This is Nicole Verdun. I'm the director of the Office of Blood Research and Review at FDA. I'm actually downstairs, but thank you.
We'll come down and bring you up, Nicole. Okay, moving on to Diane Corning. Moving on to Sridhar Basaraju.
Hi, I'm Sridhar Basaraju, Director of the CDC Office of Blood Organ and Other Tissue Safety.
Okay. Moving on to our NIH representative, Dennis. Oh, since you already, okay. Is there anybody that I've missed on the roll call that is online?
This is Colonel Andre Kapp from the U.S. Army Institute of Surgical Research.
Thank you, Andre. Okay, if not, we do have a quorum. The meeting can begin.
Thank you, Jim. Since I've already given my comments, I will just segue directly into introducing Peter Marks, who really needs no introduction in this community. He will be updating us on the advanced study and individual risk-based deferral. Peter, Dr. Marks.
Thanks very much. And I kind of broadened out the topic slightly. And so you'll hear a little bit about an individual donor risk assessment update, but focusing on the data from the advanced study. So say a little bit about a brief overview of blood safety. You guys don't really need that, but in the context of this being an open meeting, thought it probably makes sense to say a little bit about that, about the purpose of blood donor deferrals, talk a little bit about the key findings from the advanced study and where they have taken us with to the individual risk assessment policy. Whoops, there we go. So this is an old slide, but one that helps show that over the past few decades, we have had tremendous advances in blood safety. I show this because it really has shown what the combination of our blood questionnaire plus testing plus other administrative procedures have done in terms of reducing the risk of various infections. And it also helps illustrate a principle here that we have now gotten the risk for some of these infections down to below 1 in a million, such as HIV. And it's one of our principles that we're not going back, so that once we get to a certain level of blood safety, we would like to maintain that level of blood safety that we've achieved. That'll become relevant as we go on. So we've gotten to this place, as I've alluded to already, by a combination of screening our donors with our donor questionnaires and having deferral criteria, testing for various infectious agents. We have a maintenance of donor deferral lists. We have quarantine release practices, and a good quality systems that investigate and correct deficiencies. So our questionnaire, this is an example of the one that was our full-length donor history questionnaire when we had a 3-month deferral. But it has any number of questions that helps us identify concerns for either the donor themselves or for the donated blood. And our tests, which have grown over the course of time include a variety of potentially infectious agents and have actually now become somewhat regional, depending on what where one is. One may or may not have to perform some of these tests, and also seasonal, because at certain times of year, there are certain infectious agents that are of concern certain times of years that aren't at others. And we also have to deal with potential novel pathogens that come up, but that we will save for another day. Let's see. I'm not good with this clicker. So the blood guidance for HIV risk, the first deferral, which was not for HIV at the time, it was to help prevent AIDS because we didn't know that HIV caused AIDS, came about in 1983. It was finally kind of placed into guidance in 1985 in the form that it sat in for about 3 decades as an indefinite deferral in place for men who have sex with men. That was updated in 2015 to a 12-month deferral for men having sex with men. And even at that time, we made it very clear to the community that we knew that this time-based deferral was not what was desired, and that we would look to try to find something that could be more like an individual risk assessment. And actually, the advanced study that I'll tell you about, the planning for that started in about 2017. And then in 2020, based on surveillance data that we had from the transition to a 12-month deferral showing that there was no reduction in blood safety, we moved to a 3-month deferral. That happened both because of data from the United States, but also from data from countries like the United Kingdom, which had gone to a 3-month deferral and showed no increased risk associated with that. And then most recently, as we'll note, on May 10th, we moved to the individual risk assessment policy. One question that does come up often is, why couldn't we just eliminate all of these questions? Our testing is so good, right? The problem is that any test, even if it's really good, when you have somewhere between 8 and 10 million units of red blood cells, plus, well, we're not even mentioning the plasma that we collect in the United States, you end up having this issue that even at very high rates of sensitivity and specificity, you still end up potentially with units coming through because of the current epidemiology of HIV in the United States. There are cities in the United States where there are still a fair number of recent infections. Those recent infections are in younger individuals who are potentially donating blood. And this is from modeling that was done a few years ago, but there's no reason to believe it's significantly different now, that if we took away all the questions, we would potentially have units of blood coming through that might actually carry recent infection of HIV and therefore potentially transmit. So we still need some questions. And how can we do this in a way that is considered to be most equitable for blood donors? And even before other countries like the United Kingdom and Canada went to an individual risk assessment policy, we were studying this. Now, I should say, by way of just transparency, Italy and South Africa have had individual risk assessment for many years, but they had different epidemiology of HIV. They have much more heterosexual transmission, so it's a little bit different. But the study, the advanced study, assessing donor variability and new concepts in eligibility study, thankfully the group came up with that name because it was one of those acronyms that I never would have, despite being an oncologist and hematologist, I never would have been able to come up with that one, but it's a good one. It was put together with the idea of the idea was, could you come up with some simple questions that you could easily execute in the blood donor setting that could help identify those who might be at increased risk, or for that matter, at reduced risk of transmitting HIV, despite the fact that they might be actively having sex with other men in this case. And so the idea here was to pressure test the issue because we did not have tremendous resources for a huge sample size. So the study was conducted in 8 cities that were selected for the fact that they were places where HIV transmission was still actively occurring or on the rise in a patient population or a donor population of the 18 to 39-year-old ages. And so the objectives here really was to provide FDA with the evidence that we would need to potentially change our policy for men who have sex with men to one that would be individual risk assessment. And really the idea here was to figure out how these questions could predict recent infection, because really it's recent infections that are relevant here. It's infections that have occurred in the past few weeks, not long-standing infections. Eligibility, as I've noted, we wanted to pressure test this issue. So the idea was not to take anyone, it was to take people who might actually donate blood that were 18 to 39 years old, that were actively having sex with other men. The idea here was actually to pressure test this in a population of individuals who were active. And they had to answer a study questionnaire after providing informed consent and give a blood sample for which HIV testing and recency testing was performed if found to be HIV positive. And we excluded things that might exclude individuals from donating based on other donor deferral criteria. There we go, sorry. Just don't seem to have a touch with this clicker. There we go. The study design, as I mentioned, it was really a 2-visit study where the first visit was enrollment, getting the sample and filling out the questionnaire, and a follow-up visit 21 days later. I should say that this study was really conducted with great gratitude to the blood collectors, the community organizations, advocacy organizations who got it done during the middle of the pandemic. You can see the study sites: Atlanta, Los Angeles, Memphis, Miami, New Orleans, Baton Rouge, Orlando, San Francisco, and Washington, D.C. We had intended to enroll 2,000 individuals. That proved challenging during the pandemic. And because this wasn't, this was not a stringently statistically planned study, we ended up with 1,781 eligibility visits, resulting in 1,566 blood draws, and then ultimately a kind of a breakdown of individuals, some of whom were on pre-exposure prophylaxis, some of whom who were not, 4 HIV positive individuals, and we know a fair amount about some of those individuals, and those were generally long-standing infections. And 1,200 of these individuals consented to an extended follow-up interview, which allowed us to learn more about their risk factors, et cetera. Those data are still being analyzed, but I'll give you kind of the top-line data from the study here. You can see that the most individuals were enrolled in Washington, D.C., followed by Los Angeles and San Francisco. These were, as I said, 18 to 39-year-olds. Their racial distribution here, primarily white, but with some Black, interracial, and Asians comprising a little less than 30%. The majority of these individuals were never married. A quarter were married or had a domestic partner. they were a relatively higher educated group of individuals. That could be one criticism here. But about half had completed college, and about half or more earned $75,000 or more. Just to give you an idea of who was in the study, most were full-time employed. If you look, some of these individuals had donated blood previously. The people who were not eligible for the study, in case anyone's wondering, there were a variety of different reasons. Leave people they can read that. So just an important piece that came from this study was this actually the data on the amount of PrEP use in the community at this point in time was something that actually we didn't know in a population of individuals who might actually be presenting to donate blood. And you can see that it's not quite 50-50, but it's close. A fair number of individuals taking pre-exposure prophylaxis and an equal number almost not taking PrEP. This is relevant because at least currently we are uncomfortable having people taking PrEP donate blood because of the issues of PrEP potentially making it more difficult to detect HIV that has recently been acquired. So it means that we learned already that of those who might be donating blood, we would have a group of people who wouldn't be able to because they were taking PrEP. But that said, we also learned that there were a fair number of individuals that were only having sex with one other person during the past 3 months, which makes us feel that there was at least a group that would be able to donate without a deferral. So if we're going to change the policy, we want to make sure we can change it and people can donate. And this was actually reassuring. It was one of the features that led us to be able to change our policy. So there were a variety of things that led us to change the guidance. One of which had to do with the advanced study, but some of the other data we had came from the fact that we had once again had data from the transfusion transmitted infection monitoring system that showed that the change to 3 months from 12 months was not associated with any increased risk to blood safety, which was quite reassuring. If anything, things actually looked better. That also may have had to do with the fact that there was pandemic in the middle of that too. But that aside, data from Canada and the United Kingdom in particular, which had changed over to individual risk assessment about 2 years ago, indicated no increased risk. So this combination of features led us to issue draft guidance several months ago and then finalize that guidance on May 10th. There we go. The guidance that was issued on May 11th, 2023 included the recommendations for evaluating the donor eligibility using individual risk-based questions. There we go, which had the revised donor deferral algorithm of 3 months from the most recent dose. So if somebody had been on PrEP, they would have to be deferred for 3 months from their most recent dose of PrEP. This is also present in the Canadian and UK policies for individual risk assessment. We have a 2-year deferral in place for those taking injectable PrEP. Again, whether there's a slight differences here. In Canada, it's 4 months. Here, we were aligned with the UK with 3 months, and whether it's 1 year or 2 years for injectable PrEP, there are maybe differences there. But the bottom line is we're not comfortable at this time with individuals on PrEP donating. And then the business end of the deferral comes from the 3-month deferral for most recent sexual contact for an individual who has had a new sexual partner and who has had anal sex in the past 3 months, or who has had multiple sexual partners and anal sex in the past 3 months. And so the donor history questionnaire, thanks to AABB and blood collectors, was essentially moved through seamlessly at the same time as the main guidance. And so that level 2 guidance came out essentially the same day as the guidance. And so with this, we had both the level 2 guidance and the main donor deferral guidance for HIV all coming out on the same day. And we're now in a position at which, as of May 11th, I may have said May 10th before, so I apologize, May 11th, we have some blood collectors that are accepting donations under the new individual risk assessment guidance. It's understood that some larger blood collectors will take a little longer to get there because of the reprogramming necessary for computer systems. But by and large, I think I've been impressed that we're making good progress towards what it sounds like the August to September rollout of the individual risk assessment for even some of the larger blood collectors. So I think this is significant progress over time. Community members have been essentially accepting of this. I think there's still, just to be fully transparent, a desire to see if we could have some people on PrEP donating, but until we have more data, our feeling is that's just not possible. This was a major step forward, and I think it does allow us to ask the same questions of all donors, which I do think is gets us a lot further than we were previously. So I will stop there, and I'm happy to take any questions, and I apologize for my ineptness with the clicker. It's right hand.
Thank you. Any questions from the audience? Ray?
Is there any data on, other than HIV, HPV, HCV transmission?
We don't have that. We have data. We have historical data, but we don't have data. I actually don't have data from the UK on hepatitis B, hepatitis C. I think the feeling, though, is that with and that's part of the reason for the 3 months still here, rather than some people say, well, why can't we just do 1 month? But if you then start to get into issues with window periods and hepatitis B, that could be challenging. So that's another question, just by way of full disclosure, that we've gotten already from community members. Why does this have to be 3 months? Why couldn't it be 1 month? It turns out there are other infectious diseases that this helps, the 3 months helps with.
If there's no one else in the room, is there anyone online who has a question? Okay, well then, thank you very much. Our next speaker will be Jay Menitov, who will give us a background on surge capacity.
Thank you, Claudia. And Peter just explained to me how to use the clicker, so I'll try to do my best. I like history, so I wanted to start out with a little bit of history. Claudia asked me to talk about surge capacity, give the background, and I had my first meeting back in this building in 1982, July of 82. I think my shirt is still wet from the sweat of walking around Washington from that meeting. But it shows the long-term interest and role that the Office of the Assistant Secretary has taken. This meeting was scheduled here to discuss new cases of pneumocystis among 3 patients with hemophilia who had immune deficiency. Meeting took place just a couple of floors below us right now. And it asked this, really presented data to come up with new recommendations going forward for a crisis that could affect the blood supply. And we all know the tragic and transformative events of HIV, and that led to a report from the Institute of Medicine in 1995. 14 recommendations were made. The government responded to several of them, including that the Assistant Secretary of Health would take responsibility for oversight of the blood system, that BODSEC, Blood, Organ, and Tissue Senior Executive Council, would coordinate government activities, and the Secretary's Advisory Committee for Blood Safety and Availability was established as an expert panel to assure communication of blood product risks and alternatives. So that's the genesis of this committee. And this committee has, in fact, done that. Except when you push the clicker, it doesn't click. Oh, there it is. Okay. And so starting in, I went back and looked at advisory committee recommendations starting in 2006. And here there was discussion about a global pandemic related to influenza A, H1N1 virus. And the committee recognized the role of ABB's interorganizational task force that addresses blood and blood product shortages, and made recommendations to prioritize allocation of and minimize disparities in blood and blood products availability and use. So it's blood products that were mainly looked at that time. Okay, all right. In August of 2007, the committee met again and recommended that HHS develop comprehensive models to address and respond to needs for blood and related critical materials in a variety of surge capacity and conditions. In 2012, the committee again addressed this and noted that modeling efforts have indicated the likelihood of larger scale disruptions that could easily overwhelm the current response and recovery capacities of the system, that there was preparedness for such disasters that could be advanced. And among those was infrastructure, including reserves of end products, manufacturing consumables, logistics support for transportation, information technology systems, communication, and connectivity with other blood response systems. The committee also noted that there was a need for new products, extended storage of blood products not requiring, or platelet product, extended storage of blood products and products not requiring cold storage, including modified plasma platelets, red cells, and oxygen carrying solutions, things that have been addressed. Rapid low technology screening tests for infectious diseases, pathogen reduction was an important topic that the committee discussed, and also stem cell-based products and growth factors, and also made recommendations about regulatory flexibility. The committee noted that subcommittees could be established, and in fact established a subcommittee to look at surge capacity and for addressing times of national disasters. Peter, I'm glad you're not the only one who's had trouble with the clicker, because I can't figure out pushing right or left or whatever to make it work. So the committee came back in a year later in 2013 and was asked to consider, is the current U.S. infrastructure appropriately prepared to handle emergencies necessitating human tissue and or blood, and what further development was needed. And did receive a subcommittee report. Subcommittee was chaired by R.A. Shander, and it looked at defining what's the definition of the event, understanding when blood is needed versus other support to refrain from occupying needed channels. National, regional inventory data, perishable or other, needed to be considered. Initial self-limiting support versus sustained support. And implementing national, regional systems for distributing and coordination, along with a need for oversight. The preliminary recommendations of the subcommittee were identify the agency, institution responsible for blood and tissue disaster preparedness. So who's accountable, who's responsible, ascertain legal commitment from said organization, assess the need and amount of financial support, got to pay for it, establish a national daily inventory system from all blood centers in the U.S., so-called stockpile, establish a compendium of all tested concentrates on manufactured factors, and establish redundant communication, and list recommendations for field laboratories. ASPR presented at this, mainly addressing tissue, and they came up with actually presented some modeling as well in terms of the number of people who might be involved. Well, it's got to be the battery. And actually came up with the mass casualty events, number of people who might be involved or needed to be triaged or needed to be treated. So clear indication that ASPR was involved and that ASPR had modeling capabilities. And I obviously don't have clicker capabilities. So at the committee at this time, looked at that there were and noted that stockpiles of less perishable blood derivatives did not exist. Stockpiles of equipment and disposables needed to make components did not exist. Disaster preparedness to assure concurrent availability of blood and blood products is not well coordinated, and stable funding to address blood adequacy in disasters was not established. So this is 10 years ago. The committee made recommendations to establish stockpiles of devices and consumables needed to prepare blood components, establish and maintain stockpiles of less perishable blood derivatives, improve national level coordination, and establish stable funding mechanisms to support and coordinate the availability of blood. And I highlighted blood because I wanted to note the differences over time between the availability of blood and the availability of consumables and reagents needed to collect and process blood and have it available for transfusion. The committee met again in November of 2015. At this time, it was known that the RAND Corporation was going to be conducting a study, and the committee noted that maintaining an adequate supply of safe blood for transfusion is integral to public health and is a national priority. Blood utilization data understate the need to have reserves for blood on the shelf where it is really needed, and the inability in the instability in blood centers, particularly from a financial point of view, threaten to exacerbate existing spot blood shortages, reduce resiliency in the face of public health emergencies through elimination of surge capacity, and that the committee recommended that there was a need for preservation of surge capacity to address public health emergencies. And noted that the RAND report was coming out. The RAND report, in fact, did come out in the fall of 2016, and the overall findings from RAND were that the U.S. blood system under the status quo operates effectively and in many cases efficiently. Suppliers to blood centers face significant uncertainty and contribute to concerns about sustainability. This part of the RAND report. And the recommendations pertaining to surge and public health emergencies were develop and disseminate a vision for appropriate levels of surge capacity, subsidize blood centers' ability to maintain surge capacity. And it noted that some key stakeholders suggested that the blood supply should be thought of as a public good. I think we all agree on that. And then without a surge capacity to meet emergency needs, the blood system faces a classic free rider problem in which the cost of a common resource is not distributed equally. So a call to action, so to speak. And I took out a couple of things from the RAND report. Look at the top left quadrant there in terms of addressing, this is risk factors facing blood supply, and under high likelihood, low impact was a disease emergency pathogen. And then they looked at risk assessment of supply vendors. Under scenario 3 at the bottom, magnitude of impact low, supply vendor vulnerability high, national absorption capacity low, and risk of the system high. So kind of a mixed reading, but at least recognition that there were potential problems. And the conclusion of RAND was that overall, despite tight forecasting and inventory control, the U.S. blood system has been relatively resistant to disaster scenarios. They noted there was a lack of redundancy in supply vendors. To mitigate this, they recommended that blood centers should consider warehousing essential supplies rather than relying on just-in-time inventory. And additionally, blood centers can advocate for a national stockpiles of critical supplies funded by government contracts similar to medical countermeasure contracts. That was in the RAND report. The advisory committee met as the RAND report was being issued, actually just a month or so later, and noted, and I think it's important to note, that blood is a public good built on the altruism of non-remunerated donors. Simple supply and demand economic principles do not fully address the societal value of this critical national resource, and consequently, there are unique considerations with respect to sustainability of the blood system. And examples included defining and developing, or things that needed to be done, developing and defining surge capacity. And then at the bottom, among the recommendations, were explore the potential for direct payment to blood centers to cover the cost of the infrastructure required to maintain adequate supplies for the public good. And then a couple of years later, Congress passed the Pandemic and All Hazard Preparedness Advancing Innovation Act of 2019. Section 209 specifically addressed what comes about from the blood system. The advisory committee formed a working group under Jackie Frederick to help draft these recommendations, and I hope you've all seen this report. And among the recommendations, the ones pertinent to today's discussion, were adequacy of the blood supply during public health emergencies. And a couple of recommendations were made. Recommendation 4.1 talked about getting real-time data about the blood supply and utilization so that there is access to information about this vital and life-saving blood-saving life components during both emergency and non-emergency periods. And talked about mapping the supply chain so that there were heat maps and knowing where the vendors were, where the supplies come from. And then made recommendations about having task force to look at or where the supplies come from and putting together further recommendations. Try this direction, okay. The advisory committee met right after again, this is during the early part of the pandemic. Advisory committee met as that report was being finalized. The advisory committee was charged to look at lack of existing stockpiles of critical blood supplies, lack of plans for addressing transportation logistics, and to address significant financial impacts of the pandemic on blood center operations. Among the recommendations, focus area 2 had Jackie put together working groups. Focus area 2 looked at national disaster planning and business continuity and recommended developing and funding a comprehensive national disaster plan for the blood and plasma supply. Focus area 3 looked at supply chain to produce blood product recommendations, and develop policies and provide funding to strengthen the resiliency of the blood and plasma supply chain. Committee recommendations including funding a task force to establish a 6-month distributed national stockpile, or to have that stockpile of key supplies and devices, and to also manage and coordinate in that working group members from the blood and plasma industries. So I started with a prologue. I wanted to end with an epilogue, which are kind of personal comments. So prior to the pandemic, most of the focus about the blood system issues was on safety and theoretical availability. And what happened was most of those recommendations have sat on the shelf. I kind of put undemonstrated, mostly undemonstrated to be kind. Safety clearly has been addressed, and the progress is obviously exponential and phenomenal. In terms of availability, the system has been resilient. Blood is needed for the most part, except for spot shortages. It is there, despite blood centers having negative operating margins. During the pandemic and post-pandemic, noting that the coronavirus is not transfusion-committed, the blood supply issues really are based on observed problems. And the observed problems have been with the supply chain. And the supply chain disruptions have destabilized resiliency. Operating margins have been improved by the way COVID convalescent plasma is reimbursed, and you'll hear more about that as this meeting progresses. So I just wanted to end with my thoughts, and that is in terms of surge capacity concerns, in terms of putting lessons learned together. And they are for lessons learned for communicating and having recommendations that are acted upon. Focus on demonstrated flaws affecting the response to public health emergencies. But as you discuss things, don't forget to continue to discuss contingency plans for theoretical distributions. Assume the next agent is transfusion transmitted, quite different than the coronavirus pandemic. So that, Claudia, I hope I've gone through the history and gives you a sense of where to go forward. Thank you. And so, sorry about the clicker.
Thank you, Jay. That was very helpful in setting up the stage for the recommendations that we'll be dealing with today. And now we have a quick break. Just as housekeeping. Oh, I'm sorry. Yes, questions. Anyone have any questions? Yeah, Ray.
Jay, that was terrific. Your last line here, assume the next agent is transfusion transmitted. Could you almost argue, however, relative to the RAND report and how they scored this? They were scoring it according to something being transfusion transmitted, saying the probability of emerging disease was low in that particular case. Yet, as you pointed out, the most fundamental effects for a non-transfusion transmitted disease in coronavirus was the disruption of supply, the lack of people being able to work in facilities together. So what is the more important message to carry away from that? Does it have to be transfusion transmitted in order to have a major impact on blood supply safety and availability?
Both, obviously. And one of the lessons learned, I think, from RAND, if I could diverge a little bit, is when if they're going forward, if there's going to be outside organizations that look at the blood system and make recommendations, make sure that the experts putting information into the report come truly from experts with wide backgrounds. I think part of the problem with RAND is it had relatively, the recommendations are you can only get 9 outside experts in terms of some of the recommendations that come forward. Make sure that it's diverse enough and wide enough to have really good input into it. And again, RAND was put together with an arm's length approach from blood bankers, wanted this to be an outside group looking in rather than self-interest coming out at the end of the report. That's well and good, but it unfortunately obviates and prevents people with having real expertise putting input into those final recommendations. So really a long answer to your short question is, if you have the right people thinking about the future, you'll address both transfusion transmitted pathogens and also some that are not, all affecting the system. So kind of a commercial message for going forward.
Thank you. Are there any other questions from the room? We do have a question from online.
Yes, Claudia, it's Lynn. Jay, thank you so much for that reflection on where we've been and how we might consider doing things differently. What I thought was very interesting is that we, as a committee, continue to make recommendations about modeling and how that modeling may inform vulnerabilities. But so far, it feels like we haven't hit on the right models. And I think your last statement about making sure we have individuals from all walks of life, if you will, around the table to help inform the modeling going forward. If you lock into an infection transmitted by blood, you're going to not see every other aspect that could impact the system. So it's just a comment that I want to make now, and I know we'll have further discussion as we go forward. But I do think modeling is really important, and making sure we have informed variables working through the models. So thank you.
Thanks, Lynn.
Thank you, Lynn. Any other questions from online? Thank you again, Jay. This was a very helpful way to set the stage for our discussions later today. We now have a break before we're going to hear from Dr. Gorlin. The bathrooms are just down the hall, and there also is an area where you can buy food and snacks, drinks and snacks. So we'll see you back here in 5 minutes, please. In 10 minutes. In 10 minutes. At 25 minutes after the hour. Thank you.
Produced by the U.S. Department of Health and Human Services.